Good afternoon, everybody. Thanks ever so much for joining us. It's fantastic that you're here. I'm just going to spend a couple of minutes explaining where this project came from. And back in mid-March, there were two key motivations that were around. The first one is a serious one. I mean, I had two close friends who became seriously ill with COVID, and they just weren't well looked after. They weren't supported in the early weeks of their illness, but it was just shocking that nobody was interested in their contacts and who they'd been in touch with and who might have become infected. The second motivating factor was that one of the steering group members, Joan Miller, who's a former public health colleague of mine, phoned me out of the blue just to say, we've got to do something. The lack of contact tracing in this epidemic is just out of order. And, you know, in true public health style, we wrote a letter, sent it to a colleague who's senior manager in public health currently. They replied very quickly. They said, there's really no chance of getting Department of Health to change its mind. They just stopped contact tracing then, 12th of March. And, you know, local directors of public health, local authorities are having to toe the line and do what the Department of Health said. And they said, you know, this person said, well, why don't you do something off your own bats locally? So we did, is basically what's happened. We chose the Healy area of Sheffield because the Healy Trust already managed a well-organised volunteer hub, and they already had strong links with local general practice. And an important point was that we wanted a project that would strengthen the local community and increase community resilience, you know, rather than, you know, by contrast to the national scheme, which is run by private contractors with no particular links to the community. So steering group was set up, letters were sent to the British Medical Journal, articles written and all the rest of it about what we wanted to do. And very quickly, several other people joined the steering group. Crucially, Andy Jackson, who's the manager at the Healy Trust, but also other people with some key skills which complemented what we had to offer. So that's where the project came from. That's where the Sheffield Community Contact Tracers came from.
Starting off, we aim to get enough cases to get a pilot to see whether this approach worked. And I'm not planning to read out the contents of this slide. We followed guidelines, index cases, 7 days from initial contact. I think crucially for us was that this was a project about tracing and supporting and enabling isolation. So we put all of those together very much. Hence, there was a daily support contact either by phone or by text or by WhatsApp. And as you can see, it took quite a lot of time. 80 minutes is a conservative estimate of the amount of time that would be spent coming out of the index case, contacting the index case, and contacting their contacts. We didn't manage to take up all the 13 initial referrals. One we didn't take up because they had been having symptoms for too long by the time they came out of hospital and were referred to us. One we dropped because of racist abuse, and one I think the GP who had referred the person to us probably hadn't done any preparation, and the person was confused and never engaged. So thinking about the contacts, I guess the crucial finding was that although we managed to establish very good contact with 19 people as a result of this, we didn't manage to contact 39 others. They were either unwilling or unable, or more commonly, disabled by their employer from giving their name and contact details. And out of those 39, 29 worked either in the health service for one of the local hospitals in primary care, or worked for care home providers in a variety of different roles. And then the others worked in other financial organizations or whatever. And in those situations, we weren't able to make the contact and move things on. And that was a challenge for everybody, despite a lot of work from the volunteers. Moving on to Rowan.
Lovely, thank you. Hi, I'm Rowan. I'm a volunteer contact tracer. And I'd just like to tell you a bit about what it feels like to be a volunteer contact tracer. Okay, so my motivation was I had COVID, and it was a very isolated situation. I was on my own, away from home, and I had it quite badly. And that made me not a little bit scared. And it made me consider lots of things. How would my parents feel in this situation? What about if I were more vulnerable? I wasn't a fit person, and so on. How would I cope? What would I do? All of us volunteers in the team have our own motivations, and this has led to the assembly of a very diverse team in both age and experience and outlook, which I think is a huge advantage to what we're doing. So what qualities do I consider key to being a volunteer? The principal one for me is that we offer support and guidance rather than directing. And in doing that, what we really need to be doing is building up trust of both the index case, the person who's got COVID, as well as the actual, as well as the contacts, the people who have been in contact with them. It helps to understand the local context, and obviously we need to show affinity and understanding. Again, key, I think, is to be calm and clear. If we can project calmness and clearness, the people we're dealing with tend to calm down and will work more closely with us. And for me, I've found my personal experience of COVID invaluable. Right, the second thing I wanted to talk about was commitment. What's our commitment as volunteers to the initiative? From my perspective, there's two elements here, because we were running a pilot study, and then there's that as a contact tracer in itself. Our first commitment, when I first signed up, was a Zoom meeting to meet the team and my co-volunteers, followed by 5 hours of training, online training, which included practicing and managing a variety of scenarios with index and contact cases. Having received the training and before the first case, how did I feel? Well, quite frankly, nervous. I think Bing will agree with me there, because he was the one on the other end of the phone at the time. As soon as I'd had my first telephone conversation, that nervousness evaporated. My index case was so valuable, was so thankful for the support and advice they were receiving. It put a whole new light on the issue. Contact calls could be more tricky, particularly in the first instance. That's the person who's been in contact with the person who's got COVID. The reason that's tricky is because basically they are healthy, well people, and you're trying to tell them they've got to constrain themselves. So what's the time commitment? Well, an initial call to an index or contact case will take about 30 minutes. Thereafter, it's anything from 5 to 20 minutes. We follow them up, index cases for 7 days minimum, and a contact case for 2 weeks. That's every day. Then there are the notes and forms to fill in, which I think we've got pretty streamlined now and becoming a much faster process. What support as a volunteer do we receive? Well, for me, there are 4 key elements. First of all, we have support centre meetings, support circle meetings. These originally were every evening. Now we've reduced them to twice a week. They're every evening to begin with, because obviously as running a pilot, we were having to actually change, develop materials, processes and so on. and now that's more slick. We can cut that time commitment down. There are a most immediate point of reference, really. In those meetings, we seek advice, we talk over our cases with each other, we also share personal concerns and look for ways to improve our methods. In addition, initially we were each assigned a medically trained mentor whom we could contact at any time. We also have a direct line to Healy Development Trust for support with social issues, food deliveries, etc., etc., etc. And lastly, but by no means least, we have the volunteers WhatsApp group, which is great for help, advice, and for us to have a general gossip. So I don't want to run on for too long, but just to conclude, what I've tried to outline is the purpose and drive behind volunteering, the time and emotional commitment involved in volunteering, and the support structures we have in place to ensure that we succeed.
We couldn't have achieved this project, which focused on providing continuous support, without having the links to Healy Development Trust. And for us, one of the key elements is that there is a strong link there, and that we're enabling people to do this with the backup of being able to organise dog walking if that was necessary, or shopping if that was necessary. There's no doubt to us that having that local approach increased cooperation, and it enabled people who are more marginalised to feel safer, and it in other settings would have had even greater impact than it did in our small study in relation to language skills and knowledge. And passing to Bing.
Good. Okay, so employers and employment are really important. They're one of the biggest findings that we came up with from this little study. Let's run through what it says on the slide here, and then I'll talk a bit some more. So there's a big range of situations in terms of employment, but you can gather from what Mike said earlier on, a lot of the people who didn't complete their 14 days follow-up had problems at work. And the essence is that most of them were cooperative to start with, but they said they needed to talk to their managers because there were the contacts were other people at work. And they passed information on to their managers, but often the manager would say, I'm sorry, this is too complicated, we can't go any further. And generally, these people were then stopped cooperating. This is a big chunk of the nearly 60 people that we followed up. They had lots of reasons, including loyalty to their teammates, loyalty to their employers, and also concerned about money. So there are lots of reasons why employment is a problem, but the really striking thing is that half of these people, well, I think half of the 3/4 of the people who we didn't follow up completely worked either in the NHS or in care homes or in home care. And the key thing here is that these people are transmitting the virus because they're moving around. And they're a really, really important part of the contact tracing story. And the fact is that there is not adequate culture, well, there's no contact tracing in the NHS or in care homes. There's not a really satisfactory culture of social isolation within the NHS and care homes. So people are strict when they go out to the supermarket, but they're not necessarily so strict in a hospital canteen. And the really, really big one is that in care homes, there's neither the manpower nor the resources to actually self-isolate a large number of contacts when there's an outbreak. And this is going to be the biggest challenge, I think, for everybody going forwards. So the key messages are, number one, the really basic key message from our study was that nobody was doing contact tracing when we were doing. This is really, really basic. A massive omission on the government's part. Ineptitude, I would say. Second key message is that in a short time, we trained the most fantastic group of volunteers, and they really can do it. Okay, they can be trained and supported. The next message is, this is hard work. Everybody knows that contact tracing is hard work, but this is particularly hard work because there is going to be a large number of people who are going to have to take on responsibility for the whole of the rest of the population. Most people will be getting back to having fun, but these folks are going to have to pay the price with 14 days of self-isolation. One of the reasons is that people with COVID-19 don't benefit. It's not like your child who's been identified with meningococcal meningitis or something, where they can get treatment and get some benefit. Quite the opposite here. Contact tracers really need to be local. This is another very, very basic thing. So we've had lots of questions. How did your volunteers get by without any authority? And I keep replying, they did have authority. They have the authority of being volunteers, of taking the time and trouble to do it themselves. They've got the authority of being local, so they can say, look, I live near you. That's really, really important. So they are trusted, and that's very real. Early access to cases. Now, this is really important as well. If you only find somebody after 7 days of infection, people are infectious for 2 to 4 days before they get symptomatic. So if the whole thing is delayed, the diagnosis or the test, and then the information about the diagnosis or test, that's a catastrophe, because basically the index case will have spread the virus before you've identified and isolated their contacts. So early access is absolutely key. And then the whole messaging is imperative. And we've had a lovely example of the government screwing up on the messaging. And that's only going to get more complex as time goes by, because everybody will be slowly, all the rules will be changing. Most people will be doing what's normal. But the messaging here is asking a small group of people to take the flak for everybody else. Okay, and then the last point is support. Supporting people is absolutely essential. As Paul said before, if the index cases are often ill, they need help, and this can be a very debilitating disease. And the business of isolating, particularly self-isolating within your home, but also the business of not being able to go to work, is very demanding on people. So they need a lot of support. Yeah, I think that's probably pretty much it. So next slide, please.
My name is Tim Walliscroft. I'm a researcher at Sheffield University. So I've been brought in to help do a bit of the evaluation for this project. So I'm just going to go over some of the key things. So one thing I really want to stress is that just because this project was successful, it was successful for many different reasons. This doesn't automatically mean that any volunteer project is automatically going to be successful. So just think that that's a key thing. And so there's a number of reasons why it seems that this project's been successful. One key thing is the expertise and the contacts that the steering group had, the people who set this project up. So a lot of healthcare expertise, public health expertise, and so on. And that expertise was then applied through careful planning, put a lot of systems in place. Rowan was talking earlier about the support structures was put in place, that those things were absolutely key. Also, other aspects of it is also, as been said before, the local connection. I mean, this came out really, really strongly, that in terms of the process of building trust, which has already been said, is that being contacted by somebody who has shared ideas and can talk about actually things which take place in the local community actually seem to be really helpful in terms of actually developing those relationships, developing that trust in order to make this work. Something else that's also seemed really important is the ability to have it set up in such a way there's systems of continuous learning and development. Being kind of small and nimble and adaptable seem to be really key in terms of making this work. So another thing that really jumped out from the interviews I did was the impact wasn't just about getting people to self-isolate. Obviously that was important, but the impact went broader than that. So ultimately it's things like, actually, if someone is self-isolating, feeling inevitably emotionally anxious was kind of key. So there was one example that was given about somebody who was living by themselves, feeling anxious and so on, and was really appreciative about having someone phoning them up every day and feeling that they're less alone, having someone checking up on me. That emotional side seemed to be really important, as was related practical support, such as having information signposted to them. And not least was actually the impact on volunteers themselves, having the opportunity to contribute, to do something to help other people in their community and actually develop skills through this process. So then just moving into a few key learning points. Boundaries obviously is important. That came out really clearly, that volunteers being very clear that their role was not to instruct, but to advise and inform seemed to be really key. The flexibility to fit around the requirements of the people who are being contacted. I mean, obviously, people who are contacted are almost by definition not in a well state, and some of those people are only going to be well for certain times of day. So it's important that volunteers fit in around that. Also connected to that emotional side of things is there's an inevitable emotional impact on volunteers themselves. So actually having volunteers, making sure they look after themselves is really important. That's why the support structures that Rowan talked about earlier were really, really important as part of that planning which was put in place. It's a significant commitment. That's another key thing here. There's a lot of information to consider. So a key message here is that actually a lot of the volunteers actually came from fairly senior positions in their background, drawing upon past experience. One talked very much about drawing upon their past managerial experience in the volunteer role that they played. In terms of the training and so on, the quote to the right, it's about saying that actually it's complicated. Every person who's contacted is an individual. There's deals in complexity. Training is helpful. Training was helpful, but it can't prepare for everything. And actually, so something else that was put in place was actually kind of communication channels to be able to discuss issues as and when they arrived, and getting to the index cases as soon as possible, of course, was important.
So the essence is that the first thing to be said here about what's next is that even when we planned this webinar, we didn't really know that the government was going to say, hey ho, on the 27th, yesterday, there's going to be a national track and trace system, all right? It's really sprung on everybody, including us. So we are sort of flying by the seat of our pants, as we always have done. So that's the first thing. The second thing to be said is that it would be lovely if we could work with Sheffield City Council and be part of a proper, authorised, official public health service contact tracing system. And we are really well placed. We know all the right people, and we're really hopeful and optimistic. And there are particular roles there that we could have, particularly reaching hard to reach groups. There are traveling communities, there are cultural communities, and these are really important in terms of contact tracing. There are groups that are going to be hard, and we could work at that. We could do a lot on volunteer support and education. So there are roles within the local public health system if we are invited. But we have to say that we've started off being kind of independent and slightly rebellious, and we're fully prepared to keep going if we're not invited in. The next thing to be said really carefully is that a lot of the problems with contact tracing and the entire management of this epidemic is that everything has been delayed and has been overlaid with half-truth, high expectation and poor delivery. So we have to manage that, be prepared for that. It may well be that our role will be to keep going and just go on filling in the gaps and trying to highlight ongoing delays. The next idea that we had was looking at social media referral. So one of the big problems about contact tracing is delayed diagnosis, and a lot of that is to do with delays in testing, and also this massive emphasis on a positive test. A lot of negative tests are false negatives. A lot of the tests are delayed. A lot of people don't have the opportunity to get a test, and a lot of the test results are delayed. So here's our really big next idea, which is that maybe we should go back to our very original idea, which is to get people to refer themselves when they first get ill, and do that through social media. We've not developed it much, but that's really what we're thinking, one of the big things that we're thinking about in the future. And the other very big thing that we want to keep working on is the importance of community resilience. This whole COVID thing has grown out of lack of investment and lack of self-respect and lack of importance of local communities. And we've built on a bit of community resilience, and that's what we'd like to develop some more. And the last thing, we've just got to go on highlighting government failure to deliver. They are so good at talking themselves up and so bad at delivery. Good, that's about it.
So we've come to the end of the formal presentations of what we have been doing, but as part of signing up to the webinar, you were asked to identify questions that you wanted, and we've clumped those together. So the first couple of questions came from Nigel Wilson, a contact volunteer tracer, and Professor George Smith from Health Watch in Oxfordshire. And summarising their questions together, with apologies for missing anything, the question that I'm going to ask Jack to answer on this is, what's our relationship with our local authority, with our environmental health officers, and have we thought of using environmental health officers as contact tracers? And Jack should be ready to answer that. Jack's another of the steering group.
Hi, everybody. Yes, thanks to everybody for coming. I'm going to answer that question, but there's a couple of others that I think are linked. And one is to do with our links with public health nationally and locally. And I'll try and link in the environmental health officer question with that. And then there's one about community inclusion, which has come from various people in London, Anna Livingston and Eileen Conn, and from a colleague of mine in Sheffield, so that we have enough time for all the other questions, really. So we have been working, I would say, closely with the local director of public health and his team, and a couple of us sit on their planning group for contact tracing. So they've been in this position where they haven't really known quite what nationally is going to come down to them, and they've had to cope with us doing our thing in the neighbourhood of Healy, but I think quite interested in what we're doing and thinking how they might use us. So certainly at one of the meetings I was at, there were environmental health officers, there were contact tracers from sexual health and TB services, and from the infectious diseases department in the local hospital trust. So they're all engaged, although I have to say that environmental health officers have been cut to the bone over the last at least 10 years, and there aren't as many of them as there should be. But as far as I understand, the local plan is that they will be doing work in particular settings. So hostels, homeless hostels, school settings, and hospital care home, those sorts of settings. If there is an outbreak of disease, they will focus their attention on those things. We haven't got an environmental health officer on our team as such, but I think, as I said, they're few on the ground, then they probably need to be working much more on a citywide basis. We haven't had any contact from national government. That was one of the questions we had from Kevin Donovan, I think. So they haven't been in touch with us. I've no idea what they think about us. They probably think we're a thorn in their side. But as I said, we've had a lot of contact, I think, with the local director of public health, who is going to come to one of our meetings next week, I think, and their whole team of people who are mobilizing a local response, having to fit in with whatever nationally is coming down. So they're going to follow the national guidance. There are going to be the call handlers in tier 3, I think, and the clinical workers in tier 2, this is how they've defined it. And then the tier 1 workers will be working in the local authority around the hotspots, outbreaks, and the sort of settings. Just quickly moving to the, there's a question about community inclusion. I see this a bit like Bing said a bit earlier on. I see our role as probably as continuing what we're doing now until things start to sort of work their way through nationally. And we don't think that's going to happen probably for several weeks, possibly months, before they get anything properly going. So we need to continue our work. We're also talking to we've trained more volunteers, 25, I think, other volunteers have been trained and are waiting to work, and they're in other parts of Sheffield, in different communities to the ones in Healy, and also in Calderdale, because Paul Redgrave now lives in Calderdale. So we've spread that word, and we've been in touch with people in Tower Hamlets and Hackney and other areas, Frome, I think, other areas in the country. So we think that each area may have a slightly different, well, they will have different communities. So there'll be the sorts of communities that that we've talked about, where language is an issue, cultural issues, difficult, hard to engage with communities. And people, I think, one of the questions was, you know, in densely populated areas, how are we going to sort of tackle that? I think it's absolutely crucial that we have community knowledge on the ground, and that's what Andy at Healy Development Trust has, and they're already and have been doing all the work around providing food for people, medicine delivery, tackling loneliness, mental health problems that come up. So they're already doing that and linking in. Rowan talked about linking what we're doing in with what they're doing. And there are other organizations within the city, and I particularly work on the east side of the city in a community which has a large Bangladeshi, Pakistani, Somali, Yemeni communities. And we've also done work with the Roma across the city of Sheffield. So we've been doing work with the Roma for 3 or 4 years. And again, it's just absolutely crucial that there's that local knowledge, that we have people who know those communities. We can talk to them who've been trained in the contact tracing and who know what the issues are, even though those people may not actually deliver the contact tracing in the end, and we might be using the environmental health officers, the sexual health contact tracers, and the others. So I can see that if this works well on a citywide level, we could complement what they're doing. One of the big issues is funding for those community organisations, because they're absolutely stretched doing what they're doing at the moment, and so there's some negotiation to have locally. But I think national governments will surely realise at some stage that they're not delivering what they should be delivering, and they've got to provide funds and capacity much more down on a local level. And I think we have to fight for that, and politically fight for that as well. I hope I've answered those 3 questions.
Lovely, thank you very much, Jack. Moving on to a different set of questions from Sarah Tunara and Cassius Smith-Fraser, summarised as, can you please explain more about ethical approval and whether this is something that has been agreed for this pilot, and how would you compare the effectiveness of this approach compared to a national or central model? And I hope that Tim's ready to answer on that for us.
Yeah, absolutely. So in terms of the ethical approval, we have ethical approval for the evaluation from Sheffield Hallam University. So that has happened. In terms of the comparison with the national model, ultimately that was outside of the scope of what we were looking at in the evaluation. We were really just looking at, well, actually, what happened and to what extent it was successful, why it was successful, and so on. But what I would say, going back to the slides I put on the screen earlier, is that, well, there are certain characteristics of why this project seemed to work. The local connection has been emphasized a lot, and that is clearly not something which is necessarily part of the national approach. The kind of call center, Serco call center model is kind of potentially quite detached from that local connection. And so I think if we just think about what are the characteristics of these projects that's been talked about today, if you reflect on those and then reflect on what seems to be done nationally, you can perhaps see some difference and make your own mind up about which you think is likely to be most effective.
Thank you very much, Tim. Moving on to a couple of questions about funding. Joan Stewart and Martin Mayer. What funding is needed to run a program like this, and have you identified a way to resource it? And Andy, if you'd be ready to answer that, that'd be wonderful.
Hi, am I unmuted now?
You're unmuted.
Grand. So in the very short term, the answer is that we had received some COVID response funding to support shopping and prescription purchase and some of our sort of incidental costs of kind of crisis response. We were able to secure some of that funding against purchase of phones, incidental costs, volunteer expenses, comms and the like. So in the short term, we were able to respond really quickly. It was very fortuitous and it just all fell into place. Long term, we're still actually trying to work out what the deal looks like and how the city is going to move forward with its overall response and how it intends to contract or framework with the voluntary sector to do that. And we won't start conversations about how we fund that and how much it will cost until next week. And I actually don't know the answer because also it's very difficult to judge how much work, how many cases, second surge, third surges that might come downstream that are quite difficult to predict. So the answer is I don't know the answer.
Lovely. And I just saw a question come up in the chat about incidental expenses in Calderdale, and I think that doctors were involved in the steering group also managed to chip in a little bit to the cost of the phones at the beginning. Doctors aren't too badly paid, but it's not a long-term funding source, I'd suggest. But moving on to another question from Pascal, Helen Baxter and Janet Harris, or combined from them. And the question I'd like to ask Paul to be ready to answer on this is, what does a best practice national test, trace, isolate and support plan look like? How will this initiative and its volunteers work with the national programme? And Paul.
Yeah, thanks. Good question. I think that the guidance that local authorities have had just recently looks pretty sensible to me in all sorts of ways. Just shocking that it comes 3 months too late. But I think that to have sort of national coordination, I think that I would have preferred that the money that's gone to Serco to recruit the 20,000, that money to me should have gone to local authorities. But you know, to have regional coordination and to have local resilience partnerships involved in all this and treat any new outbreaks as a major incident. All these things are very sensible and the things that we used to do in public health all the time as routine. I'm just shocked that they're presenting it as some fantastic new idea. And I just think that we really should be empowering local authorities to obviously work from guidance that comes down the tree, but I think that they also need to be responding very strongly to local communities, and particularly the vulnerable communities which have been highlighted, of which there are plenty in Sheffield, and they really do need to have a much better deal than they've had so far during this pandemic.
Thank you very much, Paul. Moving on to a question from Gillian Creasy. For new areas looking to adopt any similar approaches, do you have any top tips? And I guess before asking Amber to answer this, I'm just going to point out one of the top tips is to get somebody like Amber to keep you organised, to do the slides that have been prepared for today, and along with Cheryl to keep the organisation going. Leaving doctors to run things without people managing, organising and doing the IT would be a big problem. But Amber has a much better and more definitive answer on top tips than I can give.
Yeah, so I've done a lot of the putting together the training for the volunteers, the new volunteers that we've just had. All of that is available to you if you're interested in doing something in your local area. We want to support you and we want to build on what we've learnt so that we don't all have to make the same mistakes. So in terms of top tips, get yourself linked up with local organisations, local support, and yeah, ask us if you need any help with anything and we're happy to do it. That's all I can say.
Lovely, Amber. And another question for you. What type of technology are we using? Is it working? And how do you ensure that the safeguarding of data and of vulnerable people?
Okay, so when I joined, there were 6 volunteers just for the pilot. It was very small, and we were doing the data collection forms were just pen and paper that we're doing. Volunteers were doing on the phone and filling out. So one of the ways that we've made things more secure is to move over to, we use Google Drive, which is encrypted end to end, and we have 2-step verification for that to try and keep everything secure. It's the standard that's used, so I'm confident in it, the team's confident in it, and that's how we do it. In terms of safeguarding, it's really important to have safeguarding training, especially for your volunteers, and especially that's where the local links to community organisations come in as well, because they can support you with that safeguarding training for your volunteers.
Lovely.
Can I just add to that, Mike?
That'd be lovely, Paul. Thank you.
That was part of it. Yeah. Thanks, Amber. We were just we were very aware of the sort of safeguarding issues when we set up. Issues for volunteers, issues for cases and for contacts, and also aware that we were going to hold a database, and also aware that there could be potential litigation. However, doing it has to be said, fairly quick risk assessment, we made a considered judgment that the risks of COVID-19 spreading through the community were massively more than the risks that somebody might sue us, or we might have some other issues, safeguarding issues or whatever. And so we decided, in a very sort of considered way, to wing it and get on with it. And we did our very best to follow best practice, as Amber's described about the data set. We've done our very best to be as good as we can, but we haven't let risk assessments slow us down at all. But we do recognise that if we carry on, then it'll be really important either to sort of become part of some organisation, for example, like Healy Trust, and follow their safeguarding and data issues, data protection methodologies and things, or we're going to have to get much more organised ourselves and have documents and all the rest of it. But it is something that we've taken seriously right from the beginning.
Lovely, Paul. Many thanks for that more detailed bit. And I seem to remember saying I look forward to be taken to court if somebody was getting upset. It'd be a great court case. Someone from the government complaining about data security, and our defence being we wanted to save some lives here. The last question that we had was, do we have an up-to-date picture of local transmission with regular updates in Sheffield? Is the testing likely to get good enough to speedily identify hotspots? And sometimes when looking at questions, it's appropriate to duck. And I think we feel that this is a question which is really one for Greg Fell and for the public health team, and that we can't give a detailed answer. That we do have some concerns, I think, in the group around the significant false negatives in the testing. So testing being useful for sometimes, but can be confusing, and the importance of making sure that people who have positive symptomatology don't get forgotten in the government's approach. But we don't have ourselves an immediate update picture. We have reasonably regular communication several times a week with people in the local public health team. So we are aware of the falling rates in Sheffield at the moment, and we've consequently had many fewer referrals over the last week. Those were the questions that we were aware that we had, and I think we're 2 minutes before the end of the planned hour for the webinar. Was there any other points that anybody else from the steering group wanted to just either come back to, or felt that they had missed, or that anybody who's been looking at the chat list has identified as something that we haven't come back to? Tim, you got a...
Just really quickly, so in terms of the point about top tips, the third slide I presented was essentially some top tips for what needed to be done to make this work. Also, I'm going to be putting the 5,000 word report based on the interviews and so on up on the SCCT website in a few days' time. It just needs a bit of tidying up, and that will give a whole load more detail on that. Thank you. That's it.
Lovely. I can see that there was a question: does a local authority outbreak control plan pull local and national government actions together? It would be very tempting to make a comment here which might be political about the launch timing of the national test and trace, but I think the reality, certainly tweeted by a Director of Public Health in Blackburn, was that they haven't defined how everything's working. They haven't worked out the standard operating procedures. They haven't worked out the boundaries yet. And our role from the community contact tracing program we've been involved in is to try and help sell the messages that we've learned from what we've been doing about how important it is to involve community, and how difficult it is for many individuals to take on the advice that they need to isolate, because it's a difficult thing to do, and how particularly common it is that people have emotional reactions which need to be managed and supported as we go through the entire process. So just by means of winding up, I want to thank all the rest of the Sheffield Community Contact Tracing team, everyone who's been involved in presenting. Some people from the team have chosen to stay hidden behind and not be filmed today. So thanks to them as well, to Tom, to Cheryl, to Ian, all of whom have been absolutely crucial, and to Gillian, who joined us more recently. It's been wonderful, and we look forward to getting more feedback from people and to working with all of you in the audience to try and make sure that we get a community emphasis into a national programme. Thank you.